Yeah, it's a great question. One thing I'm frequently asked is, well, it was against rivaroxaban, what do we, how would we compare it to, say, another DOAC? I would say two things. One, it was a trial against rivaroxaban, so we can only really speak to that. But the differences in bleeding between rivaroxaban and the other DOACs, say apixaban or others, is far smaller, those differences in bleeding, than the 60 to 70% reductions with abelacimab or rivaroxaban. So without a head-to-head trial, it's hard to answer that question exactly, but I certainly believe abelacimab is far safer, not only than rivaroxaban, but than any other DOAC, at least from the clinical trial data that we had. I do think if you said, what would be, you have a new therapy, what would be the population that the community would most want to use it in initially? I think it would be in the 40% or so of the patients who aren't getting anything, because that's the biggest unmet need. They're totally unprotected from stroke. And so the LILAC-TIMI-76 trial, which is the ongoing phase 3 trial, is in this most vulnerable population who's not even treated. It's too high risk of bleeding for even any of the safest DOACs. And so we designed a trial because we felt that was the biggest unmet need. But I do think that these agents, abelacimab and others, would have also appealed to the general population. As I said, the patients in Azalea were eligible for anticoagulation. And we see this remarkable safety benefit of abelacimab in that population. So I think, that's certainly something that I do believe for abelacimab and the other agents, that there's certainly the largest unmet need or most vulnerable patients, but ultimately I do think those trials against other DOACs will be important to inform, as a class, should all patients with atrial fibrillation be considered potentially for factor XI inhibition. Abelacimab in the venous thromboembolism space is being studied head-to-head against apixaban for cancer-associated VTE, so we will have that data as well. It's also a very high-risk patient population, high risk of thrombosis, high risk of recurrent bleeding. Not great candidates for DOACs, because DOACs don't have the same sort of advantages in that high bleeding risk population.